Thank you so much, Mitha, for a very nice introduction. And I'll go straight away into what about the OptoView, which we are using. Now, there has been immense amount of change in OptoView, and that's mainly because of the speed and the resolution, which has improved, the software which has come up, and along with that, the immense amount of the database which has been changing over a period of time. Now, presently, what I'm going to show you will be of the Avanti. In the Avanti, which is a Fourier domain OCT, the speed is approximately 70,000 A scans per second. Depth resolution is 5 microns, and also show you some pictures perhaps in cases of the earlier RTBU OCT. Now, the normative data is one of the most important things that we must look at. And in the RTBU normative databases was collected from 10 clinical sites worldwide with 555 eyes which were enrolled in the study, mean age being 49.4, but the range has been between 18 and 82. What must be remembered is that we cannot do it in children, which is so important also for us. Ethnicities have been covered up like Asian, Hispanic, Caucasian, and African American. It scans the ONH, that is the optic nerve head, the ganglion cell complex. It also has an enhanced macular map scan, that is EMM5 scan. And so now let's have a look at the first, that is the Avanti report, that's the printout. So the first part of the scan that is there, that contains the normal information that is shown in every scan. That is the age, sex, examination of date, the time and birth, the date of the birth of the patient, as well as the patient's registration number, so that when you do the next scan, you have to verify that these are definitely the same and now you're not doing it for another patient. Oftentimes mistakes occur in this. Now comes a very important factor, and that is the quality of the scan. This is denoted in the OptoView in the form of signal strength index. As per the manufacturer, it should be 40. Now, even up to 35 people take it as, accept the scan. Why is this so important is that sometimes you'll find that when your strength, the signal strength increases, your retinal nerve fiber layer also becomes thicker. It becomes an improved resolution also is seen because when your signal strength is better. Now, if you have a look at this particular the picture that I have shown, in this is of the GCC, the first one, that is with a lot of green and red. The SSI has been shown to be 41, whereas on the same date when the optic nerve head has been detected, it is 25. Now, on the same patient, in the same eye, why is the signal strength different? That is because when obtaining a GCC scan, the patient looks straight ahead and therefore you get a better scan. Whereas when obtaining an optic nerve head, the patient looks on the nasal side. Therefore, the iris as well as media opacities may affect the scan. Now let's go on to how do we obtain the optic nerve head scan, which is a very, very important scan. So first of all, you have the circular scans, which can be taken around the optic nerve head, and the radial scans. Mind you, both the scans have the centration is the center, they share a common center. The circular scans which are determined, these circular scans are for determining of the PP, that is the peripapillary retinal nerve fiber layer. The diameters of these scans vary from 1.3 to 4.9 millimeter. And whereas the radial scans are 12 of them, this is for determination of the optic nerve head margin and also for shape, and all they are approximately 3.7 millimeter in length. Once this has been obtained, after that, we have to determine this is how a map looks like. And this is first of all the optic nerve head, and this is the optic cup. And after that, you can see that here will be the retinal nerve fiber layer. And this retinal nerve fiber layer in this particular patient is green in color. And after that comes the sectors that is of the retinal nerve fiber layers. In this is the inferior and this is the superior. This is the temporal and this is the nasal. And this is the comparison with the normative data, which is present right at the side of it. In comparison, I'm showing you another patient who has, if you notice, this is red in color, the bright red color and yellow colors showing that they are very good nerve fibers, thickness, both superiorly as well as inferiorly. And along with that, there's hardly any thinning. And again, if you look at the normative data in comparison, we find that it's all green, therefore it's very good. And if you look at the retinal nerve fiber layer thickness profile, which is extremely important again, then this is done in comparison to the normative data, green which is very good, which is in normal, yellow, which is borderline, and red, which is shown in less than 1% of the normal population. And therefore, when we trace the retinal nerve fiber layer profile into this, we find it's all in green, and therefore this is a normal nerve. What is to be remembered that the retinal nerve fiber layer, the area of the diameter is around 3.45 millimeter around the optic disc. Now, this is a very important concept because this is different from the different machines. In the OptoView, in order to determine what is the contour of the retinal nerve fiber layer, what they do is a circular scan is taken around the optic disc. And by this, there are certain bright layers that we get. The first bright layer that we get is the inner retinal nerve fiber layer. Then comes the second bright spot, that layer that we get, and this one, and this is the outer retinal nerve fiber layer. And finally, we come to the ISOS junction, and this is where the retinal nerve fiber, RPE ends, and this is a very important thing. On the other hand, now when we take a radial scan, this radial scan is passed into the optic nerve head, and this has again showing the same layers. Now, when we see the same layers over here with marked by the yellow, we find the ISOS junction terminates as it touches the optic disc. And every time you do a disc evaluation, you'll find that you'll come to the same point. Now, the tomographic landmarks, this are not present in the field, in the printout. You must go along and see it in the OCT as it is being done, or even later on, and there is no segmentation present in the printout. Again, to go back, so we have in this scan, if you can notice, this scan is not correctly placed, it's not centered, it's a 3.4 millimeter diameter radial scan in order to determine the optic nerve head shape, etc. Then comes the segmentation, which is very important for everybody to see, that the top part of the segmentation should not be moved out, because in that case, you'll be missing data. And then again is the termination of the retinal pigment epithelium in the ONH border. This is completely different from the spectralis and the Cyrus machines. And if you look again I repeat, this is the optic cup, this is the optic disc, and this is the nice thick retinal nerve fiber layers. And then after that, it is telling us about what are in each of the 16 segments that are present over here, which are very, very important for us to see as to, and the figures which are present. That means that each particular segment, how much of nerve fiber thickness is present must be also seen. So in many of the maps, we only get to see 8 of them. So another comparison where you have a look at this, that here the upper part, this is the superior, temporal and nasal, it shows the thinning of only 71 and 56 nerve fiber layer thickness, and inferiorly 94 and 68. It's very important for us to have a look at these small clock hours defects which may be missed if we just look at the sectoral average. That means because we are covering up a larger area, therefore we might miss these small defects. We must take them both together. The next area that we must have a look at are the optic nerve head parameters. The first one that tells us is what is the disc area. Very important because it will tell us if we are dealing with a large disc, as is mentioned by Medha. Then it tells us what is the cup area and the rim area. Very important also is the volume, the rim volume, nerve head volume. And what is very important for all of us, which we determine also clinically, is the cup disc ratio. And also it tells us the average RNFL thickness, where on a diameter, again, of, I'm repeating, 3.45 millimeter, it is 101, which is almost normal. Now comes the next is the profile map. This is very, very important in this particular phase. It is picture, it is black is the red is the right eye, and blue is the left eye. If we look at it, the right eye, it is showing good humps and it's present. The humps are very good and it's all in the normative data. Whereas in the left eye, we find that the humps are definitely low and it is more towards the red, showing that there is an advanced effect. But very important for us to look at is the symmetrical graph, because remember that glaucoma is a disease of asymmetry, and you find that there is immense amount of asymmetry between the right and the left eyes, both in the temporal area as well as in the inferior area. And then we come down to the other important factor, and that is the ganglion cell layer. This will help us to detect what are the problems and changes that take place in a case of glaucoma or suspicion of glaucoma. In fact, earliest changes take place because earliest is macular thinning, which takes place. So in the RT-View 100, it's a 7.7 millimeter square which is being taken, and there are 15 vertical line scans which are done, which are 7 millimeter wide. And the center is not right at the fovea, but it is slightly temporal to the fovea, approximately 0.75 to 1 millimeter temporal. And after once the ganglion cell layer in an optoview consists of the retinal nerve fiber layer, the ganglion cell layer, and the inner plexiform layers. Once we have acquired these pictures, then the software, it computes it into 3 color-coded maps. So first is a thickness map, where the colors are, if it is blue are the cooler colors, if it is black, it suggests more severe loss. Then there's a deviation map. This plays what is the percentage of thickness with respect to the normative data. And if the significance map, now this is the statistical significant thickness from normal. So there's a percentage thickness and the statistically significant thickness. These are 2 different things. So just to show you how the inner retinal layers, this is what we are measuring with the help of the optoview. The B scans are, there's the B scan, which shows the entire GCC complex, and the software then segments it into by the algorithms present, it segments into the various layers. So this is how the GCC looks like. This is the thickness map. As you can see that this is nice and blue, and this green, which shows that it's a good layer. If you look at this inlet, this is mind you the fovea, and this is not the optic cup, but this is the fovea. And this gives us a segmentation of the layers, as I've said about with the 3 types of scans. And what we have to remember that there are no ganglion cells present in the fovea. Now, if we look at what about the thickness map, this is the first. So these 3 are the maps which come in. So thickness map, deviation map, and the significance map. And we find the significance map again, the GCC average is very, very important. It shows all the parameters. And here this is showing us that the fovea is marked. This often gets mistaken by people as the optic disc. And these are the summary parameters and which must be seen. Now, most important in this is the FLV and the GSV. The FLV shows significant loss of GCC numerically, and it's the most sensitive parameter signifying difference. Now, if we look at the visual field and the GCC, we find that it's a 10-2 is a very important thing that we must do. Now, in this is showing a severe structural loss, and this is correlating with the visual field. Similarly, advanced, which is showing a significant loss in the form of red and the visual field. And again, the GCC as well as the RNFL, which are corresponding. And this is the progression analysis. And this is the GCC analysis, which is showing us also the rate of change in this. And this is the RNFL analysis, which is again showing the rate of change in here, which tells us how we must prepare. So if in RTView, in RNFL progression, if we have a 10% loss, if it is confirmed, then we know that there is an RNFL definite loss. In GCC, we find that if there is a 5% loss, again, this is again very important. So there's one patient, 42-year-old. She had thin, CDR was thin, was 0.7, NRR was thin, and she had a pressure of right eye was 25, and thin corneas, as you can see in the right eye, there's definitely a change. And the OCT has confirmed that there is thinning. This is corresponding with the field. The 70-year-old, 4-year-old man who again has 0.7 and 0.9, pressures were high, and the CCT was lesser. And this is also showing the field effect. And most important, this is the FLB and the GLB. And most important for us is therefore to choose the right protocol, adjust the scan, check the strength, check the signal profile, check correlation with visual field, compare the normative data, involve the patient, of course, consider the cost of the patient. Thank you for a patient hearing.